Hello, wonderful staff of the Northwest Kidney Center, particularly at the flagship unit in Kent, with a shout out this month to our friends in Enumclaw. Today we're going to talk about what dialysis actually removes. As you know, there are two main purposes of dialysis. First, we want to remove fluid from the patient, but we also want to remove waste products from the patient, and the latter is the focus of today's talk. So dialysis removes waste products through the process of diffusion. But diffusion also removes compounds from our blood that are not necessarily considered to be waste products, most importantly medications. So today we will discuss specific medications and chemicals that are removed during the dialysis procedure and how this impacts the care of our patients. We have three objectives. First, I want you to understand how dialysis removes waste products. Second, recognize the pharmacologic properties of medications that makes them more likely to be removed by dialysis. And finally, understand how medication dose or timing of administration needs to be adjusted for dialysis. In order to understand this talk, it's important to understand what dialysis is and how it actually works to remove waste products from the blood. In general terms, of course, dialysis is mechanical treatment for kidney failure, but more specifically, it works by diffusion. And diffusion, if you recall, is the movement of particles from an area of high to low concentration. More specifically, dialysis is the diffusion of particles across a semi-permeable membrane, so a membrane that allows certain substances to pass through and not other substances. Of course, hemodialysis involves removal of blood from the body of the patient through tubes to the artificial membrane, and that is called a dialyzer, which is the artificial kidney. And in their dialyzer, there is a semi-permeable membrane that separates the blood from the dialysate. And dialysate is just an aqueous solution similar to normal saline, plus it has glucose and other electrolytes such as magnesium and calcium. The dialyzer is a wonder of modern medicine. It contains thousands of porous, capillary-like fibers which carry blood within the dialyzer shell and serve collectively as the dialyzer membrane across which blood and dialysate flow. Blood flows through the inside of the fibers, so these thousands of tiny hollow tubes the size of hairs, and dialysate flows around the outside of the fiber. And they are separated from one another by these microscopic holes or pores within these capillary tubes across which diffusion can occur. The ease with which a medication can be removed with the dialysis procedure depends on something called drug dialysability, or how readily a drug can pass across the dialysis membrane into the dialysate. When a medication can be removed with dialysis, we characterize that medication as being dialysable. So what determines drug dialysability, or how well a drug can be removed during dialysis? So the extent to which a drug is affected by dialysis is determined primarily by four properties of the drug. These include molecular size, so how big the molecule is, protein binding, i.e. the affinity of that drug to bind to proteins in the blood, something called the volume of distribution throughout the body, and finally water solubility. In addition to these properties, there are certain technical aspects of the dialysis procedure, such as the membrane that's used, or the blood flow rate, or the dialysate flow rate, that can also impact the extent to which a drug is removed by dialysis. There are a few basic rules that govern whether or not a drug is dialysable or not, and not surprisingly, size matters. So dialysis is dependent upon the use of a dialytic membrane that has holes in it. So again, this is a synthetic membrane with fixed pore size, and as in hemodialysis or in peritoneal dialysis, you have a naturally occurring peritoneal membrane that has pores in it. So the movement of drugs or other solutes is largely determined by the size of these molecules in relation to the pore size in the membrane. So smaller molecules in general can pass through the membranes a lot more easily than larger molecules. In general, molecules that have a molecular weight less than 500 Daltons are easily cleared, whereas larger molecules, say greater than 2,000 Daltons, are not. Now with peritoneal dialysis, a common assumption is that the pore size of the peritoneal membrane is somewhat larger than that of modern hemodialysis membranes. And that is based on the observation that larger molecular weight substances appear to cross the peritoneal membrane to a greater extent than they do across the hemodialysis membrane. Protein binding is another important feature or pharmacologic property of a medication that impacts its ability to be removed from the blood by dialysis. Drugs often bind to proteins in the blood, such as albumin or alpha-1 acid glycoprotein. These are large proteins, and when drugs bind to it, then you have a very large complex that's just way too big to fit across most dialysis membranes. Now, drugs that don't bind to proteins in the blood are considered unbound because they're smaller in size, they're not complex to a larger protein, so they're able to cross the membrane much more easily. Interestingly, uremia or kidney failure appears to reduce the affinity that certain drugs have at binding with proteins. So in other words, when you have a patient who's on dialysis, particularly if they're uremic and not well dialyzed, then they have more unbound drug in their blood, and that favors removal of the drug with dialysis. So patients who are on dialysis, oftentimes, particularly if they're not well dialyzed, are more susceptible to drug removal than those who are very well dialyzed. In peritoneal dialysis, since the peritoneal membrane does permit the passage of some proteins, there may be a bit more removal of drugs that are complex to protein with that modality. But there's more to the story of drug clearance than just molecule size and affinity to bind to proteins in the blood. Even small unbound molecules may not necessarily be efficiently cleared by dialysis, and that's because of a concept called volume of distribution. If a drug has a large volume of distribution, meaning that it is widely distributed throughout the tissues, within the cells, within the interstitial space, then it may be present in relatively small amounts in the blood, and then less is available to be removed by the dialysis procedure. Factors that contribute to a drug having a large volume of distribution include its degree of lipid solubility, so how well it can dissolve in fats or oil basically, as well as low plasma protein binding. Highly lipid soluble drugs, say vitamin D for example, tend to be distributed throughout the tissues, and therefore only a small fraction of the drug is present in the plasma and is accessible for dialysis. General rule of thumb is that drugs with a volume of distribution greater than 1 liter per kilogram are poorly dialyzed. An example of that is lithium. So lithium is atomic number 3 on the periodic table. It is a tiny, tiny molecule. It is highly water soluble, but it has a fairly high volume of distribution, and therefore it takes longer, sometimes multiple dialysis sessions, in order to effectively remove it from the patient. Another property of medications to consider is water solubility. So the more water soluble a chemical is, the more dialyzable it is. And that's just because dialysate is an aqueous solution, so it's liquid. And so the chemical has to be able to dissolve into the dialysate in order to be removed with the dialysis procedure. In general, drugs with a high water solubility will be dialyzed to a greater extent than those with high lipid solubility. And as I mentioned earlier, there are certain dialysis factors that impact how well a drug can be removed. For example, the dialysis membrane. Dialysis membrane has certain features, including its pore size, its surface area, its geometry, and these impact how well a molecule can be removed. In general, the bigger the pore size, the larger the surface area, the easier it is for molecules to be removed across the dialysis membrane. And this has increased a lot, over the last couple of decades. Basically, we have much larger, more efficient filters now, and so we're seeing a lot more clearance of medications with the dialysis procedure than we used to. In contrast, peritoneal dialysis uses a natural membrane, and so nothing really can be done to alter its characteristics. In addition to the dialysis membrane, other dialysis-related factors can affect the clearance of medication. These include blood and dialysate flow rates. In general, if you increase blood flow rates during the hemodialysis procedure, you will deliver more drug to the dialysis membrane, which facilitates its clearance. Similarly, if you have a high dialysate flow rate, it flushes out the drug when it moves to the dialysate side, and that maintains a gradient between the blood and the dialysis side, and that also favors diffusion of the drug across the dialysis membrane. In peritoneal dialysis, there's not a lot we can do to alter the blood flow rates of the peritoneum. However, you can affect dialysate flow rates by, say, the volume and frequency of dialysis exchanges. So if you use a larger fill volume and you do more frequent exchanges in general, you can remove more drug with the peritoneal dialysis procedure. Or similarly, if you use really low fill volumes, infrequent exchanges, then you'll remove drugs at a slower rate. So that was a general theory of how drugs are removed. Let's now turn our attention to specific substances, medications, and other chemicals to which our patients are often exposed. So blood pressure medications are often removed by the dialysis procedure. And the significance of this is that if you remove, say, 40–50% of the drug during the procedure, then blood pressure can rise over the course of the treatment. Examples of blood pressure medications that are removed with dialysis include ACE inhibitors, so all are dialysable except for something called lisinopril. And in general, for example, you'll remove about half of the ACE inhibitor, so 50% of the lisinopril will dialyze out during a single treatment. Beta blockers, atenolol and metoprolol are dialysable. About 75% of atenolol is removed during one treatment. After dialysis, sometimes we have to give patients an additional dose of antihypertensive, so you might need to redose the lisinopril, redose the atenolol afterwards. But this becomes cumbersome. Patients forget to do it. Prescribers forget to prescribe it. And so I'm not a big fan of using antihypertensives that are filtered out of the patient during dialysis. So instead, we often use medications such as angiotensin receptor blockers. None of these are dialysable. Other beta blockers, labetalol and carvedilol, are not removed by the dialysis procedure. Calcium channel blockers, amlodipine, is not dialysable. Many different antibiotics are removed by dialysis, and that's the main reason why we administer them at the end of the dialysis treatment rather than before or during dialysis. Practically, there are really only a few antibiotics that you need to be familiar with if you work in a dialysis unit. These are vancomycin, cefazolin, and ceftazidime. The latter two belong to the same class of medication called cephalosporins, similar antibiotics. Vancomycin has a fairly large molecular weight of about 1.5 kilodaltons, but it has a low volume of distribution of less than a liter. And so, based on our earlier discussion, you'd expect that at least some of it would be removed with dialysis, and it turns out about a third of the drug can be removed during one dialysis treatment. So that's why we give it during the last hour of dialysis. Cefazolin is a small medication with a molecular weight of 477 daltons with a very low volume of distribution. It is highly dialysable up to 50%, which is why we give it during the last 5 minutes of dialysis, and we turn the dialysate off during that time. Ceftazidime, also a small molecule, 637 daltons in weight, low volume of distribution of only 0.25 liters per kilogram, and it is highly dialysable up to 80%. Same thing, we give it at the end of dialysis with the dialysate turned off. As an aside, these medications happen to be also renally cleared, and so one can dose them usually just at the end of dialysis, and that would last them for 48 to 72 hours. So these are very convenient medications to administer to dialysis patients because of their renal clearance. Some, but not all, pain medications are removed with dialysis. Morphine is a small molecule, 285 daltons, that is highly dialysable. About 25 to 50% of it is removed during one treatment. So it's best not to take it right before dialysis because some of it will be dialyzed out. So it's better to take after dialysis or consider a supplemental dose after dialysis. Hydromorphone, also known as Dilaudid, is also a small molecule, 285 daltons, and it's easily dialyzed with up to 40% of its the plasma dose removed during dialysis treatment due to its low molecular weight, high water solubility, and low protein binding. In contrast, methadone is a long-acting synthetic opioid taken by several of our patients with a history of intravenous drug abuse. Small molecule, but it's mostly protein-bound, so it's not significantly removed by dialysis. Tramadol is it's an opioid receptor agonist. Also has selective serotonin norepinephrine reuptake inhibitor activity. So basically, it's like an antidepressant too. Basically, it's highly dialyzable, so about 50% of it's removed with the dialysis treatment. So same thing, don't take it before, take it after the dialysis treatment, or use a supplemental dose. Many of our patients take medications for neuropathic pain, such as gabapentin or Lyrica, for various reasons, for neuropathy or for restless leg syndrome. Both of these are very small molecules, they're water soluble, they're easily extracted during the dialysis procedure. Tylenol, small molecule, but it's not removed very well with dialysis, and in fact dialysis can be used in the setting of a severe overdose of Tylenol or acetaminophen. Finally, non-steroidal anti-inflammatory drugs such as ibuprofen, small molecules, about 50 to 20% removed with dialysis. Now let's discuss some of the medications that we routinely administer to our dialysis patients. One of them is Mircera, or methoxy polyethylene glycol epoetin beta. It is an erythropoietin stimulating agent. Happens to be a very large molecule. The average molecular weight is about 60 kilodaltons. That's huge. So you know based on size alone that it is not going to be removed by dialysis. Also happens to have a really long half-life, which makes it last for a long time in the bloodstream, and this, coupled with the fact that it is not removed during dialysis, allows us to administer it very infrequently, say every 2 to 4 weeks, which is very convenient. What about iron sucrose? So you can see the chemical formula. Middle-sized molecule, 887 daltons in weight. Fortunately, it is not significantly dialyzed, and that's why the nurses can administer it at any point during the treatment. Beginning, middle, end, doesn't really matter because it's not removed with the dialysis treatment. What about vitamin D? So there are lots of different activated vitamin D analogs that we administer to our patients, including calcitriol, small molecule, molecular weight 417 daltons, small volume of distribution. Hectorol, molecular weight 413 daltons, so another small molecule. Volume of distribution is larger, it's 2.5 to 5 liters, so you know from that it's not going to be removed well with dialysis. And finally, paracalcitol or Zemplar, small molecule, but again a very large volume of distribution of 23.8 liters per kilogram. So these are small molecules. They are lipid soluble, okay, which is why they have, at least Hectorol and paracalcitol, have a large volume of distribution, and they are not removed well with dialysis. So again, we can administer at any point during the dialysis treatment, knowing that dialysis does not remove it. Is glucose removed with dialysis? This is clinically relevant because sometimes a dialysis patient will come in with a glucose of 600, or sometimes you'll have a patient who has frequent hypoglycemic episodes and you want to know, is dialysis contributing to this? Well, it turns out that glucose is a relatively small molecule, has a molecular weight of 180 daltons, although it does have a fairly large volume of distribution, but still it is removed from the plasma during dialysis. One study found that blood glucose levels were 36% lower 2 hours after dialysis than before, and the incidence of hypoglycemia is highest during the 60 to 120 minute period of dialysis. Patients with diabetes who undergo dialysis have lower glucose levels on dialysis days than on non-dialysis days. Recall that dialysate also contains glucose, specifically in the form of dextrose, which is chemically identical. So if a patient's plasma glucose falls below 100, then glucose will move from the dialysate into the patient, and this will help minimize the risk of symptomatic hypoglycemia during a dialysis treatment. What about protein? So we know that dialysis patients over time lose muscle mass. Dialysis is a catabolic procedure. Are we removing protein from the patient during dialysis? And the answer is yes. During each dialysis session, about 6 to 8 grams of amino acids are dialyzed out of the patient. This is about the amount of protein present in one egg. And it is one of the reasons why we administer a liquid protein supplement to the patient during the treatment, specifically to replace the amount of protein removed during the dialysis procedure. Some observational studies have suggested that protein supplementation during dialysis improves clinical outcomes, although the quality of the data is not great. Levetiracetam, or Keppra, is a commonly used seizure medication in dialysis patients. Unfortunately, the drug can be easily removed by dialysis because it is a small molecule with a molecular weight of 170 Daltons, has a very low volume of distribution, is highly water soluble, and there is no significant protein binding. Approximately 50% of the plasma level of Keppra is removed during each dialysis treatment, and seizures towards the end or after dialysis can happen because the drug falls below the therapeutic level. So dialysis patients are supposed to take a supplemental dose, so an extra dose of Keppra after each dialysis session, although again, sometimes it becomes cumbersome to remember to take this and patients forget and they have a seizure. Does dialysis remove infections such as bacteria or viruses? The answer is no, because these pathogens are just plain too big. The holes or the pore sizes in the dialysis membranes range from about 10 to 100 angstroms, and viruses range from 20 to 400 nanometers, or 200 to 4,000 angstroms. So they're just too big to pass through the microscopic pores of the dialysate membrane. Plus, the COVID virus weighs about 215 kilodaltons, so it's way too big to be filtered out by dialysis. Bacteria are even larger than viruses. E. coli is up to 100 times bigger than the average virus, so they clearly are not removed by dialysis either. How about alcohol? Does dialysis remove alcohol? Yep, it is effectively removed by dialysis. Once I had a patient who was completely drunk when he showed up for his dialysis treatment, but he was sober by the time he left because we removed most of the alcohol from his blood during the dialysis treatment. In general, hemodialysis removes alcohol about 4 times faster than the body can metabolize it, which significantly shortens the period of inebriation. Now, dialysis can also be used to treat alcohol toxicity. Sometimes patients, for example, present to the hospital having consumed various types of toxic alcohols, and we treat them with dialysis. For example, ethylene glycol is present in antifreeze, and sometimes people drink this in a suicide attempt, and dialysis is often employed to treat them. Isopropyl alcohol. This is rubbing alcohol, often used in hand sanitizers and disinfectants, and sometimes alcoholics drink it because they don't have access to ethanol, but isopropyl alcohol is very toxic, and hemodialysis is an effective way of removing it from the blood. For fun, I wanted to let you all know that caffeine is also highly dialyzable, and that's because it has a low molecular weight, it is water soluble, plasma protein binding is low, and it has a low volume of distribution. One study found that hemodialysis reduced caffeine levels by 62.5%. So if you have a dialysis patient who drinks a lot of coffee, it is possible that the abrupt withdrawal or removal of caffeine from the blood can precipitate caffeine withdrawal and make them feel very bad, cause headaches and tremors. Hemodialysis incidentally can be used to treat caffeine intoxication, which can cause various electrolyte imbalances and hemodynamic instability. Alrighty, time to summarize what we've learned today. First, how easily a molecule is removed on dialysis depends on its size, volume of distribution, lipid solubility, and protein binding. Dialysis factors can additionally influence drug removal, say the type of filter that's used or the blood and dialysate flow rates. Drugs are most easily removed if they are small and water soluble and have a small volume of distribution and poor affinity to bind to proteins in the blood. Dialysis removes many antibiotics, including vancomycin, cefazolin, ceftazidime, which is why they are administered generally at the end of treatment. Many hypertensives are also removed with dialysis, including ACE inhibitors and some beta blockers. And this can in part explain a rise in blood pressure during the course of the dialysis treatment because we are removing their antihypertensives. Most drugs that we administer on dialysis are not removed by dialysis, including Mircera, intravenous iron, and vitamin D analogs such as Hectorol. Some but not all pain medications are removed with dialysis. So yes to Tylenol, ibuprofen, gabapentin, pregabalin or Lyrica, morphine, and Dilaudid. Methadone, however, is poorly removed with dialysis. Both alcohol and caffeine are efficiently removed with dialysis and in theory could precipitate withdrawal. And finally, dialysis does not remove infection because viruses and bacteria are too large to fit through the microscopic pores in the dialysis membrane. All right, I hope you're paying attention because this is going to be a tough quiz. Question number 1. A man who drinks 12 cups of coffee per day always develops a headache while on dialysis. Why is this? That's right, caffeine withdrawal. Recall that caffeine is very efficiently removed by dialysis, and if someone drinks a lot of caffeine every day and then we abruptly remove it on dialysis, we can precipitate caffeine withdrawal. Question number 2. Mrs. Smith's blood pressure always rises during the last 2 hours of dialysis. She takes lisinopril and atenolol for blood pressure. Why does her blood pressure rise? That's right. Both lisinopril, which are ACE inhibitors, and atenolol, which is a beta blocker, are easily filtered out during the dialysis treatment. So you abruptly withdraw the antihypertensives and their blood pressure will rise. Question number 3. Mr. Jones takes methadone. He complains of pain after dialysis and attributes this to methadone removal during his treatment. Is this correct? The answer is no. Methadone, small molecule, but protein bound, is not removed efficiently with dialysis. So very little methadone is removed during the treatment. This patient does not need a supplement after dialysis. Mrs. Flamingo has COVID-19. She wants to know if dialysis will help her recover faster by removing the infection from her bloodstream. What do you tell her? The answer is no. Viruses and bacteria are much too large to pass through the pores in the dialysis filter. Mr. H takes gabapentin for restless leg syndrome. His restless leg syndrome is always worse towards the end of his dialysis treatment. Why might this be? That's right. Gabapentin is a small molecule that is water soluble, not very protein bound, so it is freely filtered out during the dialysis procedure. This concludes the September 2024 in-service for the Northwest Kidney Center. I hope you all are having a great start to your fall. Thank you for your attention today. Thank you for your excellent service to our patients. This is Andy Brookenbrough signing out until next month.